Type 2 or hypercarbic respiratory failure results from poor ventilation leading to CO2 accumulation. We can fix that either with invasive or non-invasive ventilation, and the two parameters that we can titrate to fix that ventilatory issue is either respiratory rate or tidal volume. Bilevel positive airway pressure, or BiPAP, is the ideal non-invasive mode to fix hypercarbic respiratory failure. In BiPAP, we set both an expiratory and an inspiratory positive airway pressure. The difference between the EPAP and the IPAP determines the tidal volume the patient receives. The larger the gap, the larger the tidal volume. And we have to take all of that into account as we titrate BiPAP for the patient. We can start at 10/5, but if we go from there to 15/10 to 20/15, we haven't changed the gap between the EPAP and the IPAP, and so we're not improving the tidal volume the patient's getting, and we're not going to relieve that hypercarbic respiratory failure. Instead of that, if we're starting at 10/5, we want to go to 15/5 and then to 20/5. The larger the gap, the larger the tidal volume the patient gets, the more CO2 they're going to blow off, and the more likely that our non-invasive strategy is going to improve that patient's hypercarbic respiratory failure.